This time is a very cool topic also, current concept and diagnostic significance of molecular alterations in salivary gland cytology. So a very tough and a very important point of view from the molecular alterations. And I'm really happy and honored to have as a speaker Professor Niels Rupp. If you can go with the second slides, we can just briefly, I can introduce Professor Niels Rupp, but I'm sure that all of you already know his amazing job. He's a senior attending physician at the Department of Pathology and Molecular Pathology at the University Hospital of Zurich, and all that has an assistant professorship in the same university. Of course, his clinical and academic expertise is head and neck pathology, oral and maxillofacial pathology, thyroid, and GQ pathology. And of course, he is internationally recognized for the molecular cytology contribution for the salivary gland. Also, I would like to underline that he is one of the co-authors of the WHO Head and Neck 5th edition, and as well as the ICCR dataset on carcinoma for the major salivary gland. So it's really my pleasure to introduce this talk. You can put in the chat all the questions that we will discuss all together as at the end of this talk. Thank you so much, everyone, and especially thank you so much, Niels, for this talk. You can start.
Yeah, thank you very much for the kind introduction and also the invitation. It's a great pleasure and honor to be here today and to talk about my favorite topic of molecular alterations in salivary glands. So here are my disclosures. And so I directly want to jump into this exciting topic and show you how we do classify salivary gland neoplasms, or how our approach is to salivary gland neoplasms. So in general, we use three different categories for our approach. On the one hand, the oncocytic neoplasms, the monophasic neoplasm, and the biphasic neoplasms. In the next 45 minutes, I want to give you a deep insight into how we do molecular cytopathology on these kind of neoplasms, and how this can help to classify in particular difficult neoplasms. So as you all know, many of you will use immunohisto and immunocytochemistry for a better classification. This is widely available. However, already FISH isn't that easy available. And also next generation sequencing is, in our opinion, the best way to deal with difficult lesions. However, I'm aware that it's not available at any place throughout the world. So when talking about salivary gland neoplasms, certainly we have to mention the Milan classification. And in particular, we are dealing with the difficult lesions with a higher level of risk of malignancy. And these are in particular the classification or categories 3, 4B, and 5. So today we want to mainly focus on these categories, which are difficult to classify and where the molecular changes or alterations can significantly help to improve the diagnosis. So some while ago, we were struggling with these kind of alterations because many of these weren't covered in any commercial panel, or we had to do a lot of different FISH investigations. So this was a time-consuming and also very expensive approach. And so we decided to design a salivary gland-specific panel, which can detect most of the known alterations with just one approach, which means that we only need RNA extraction of the histology or cytology specimen. So it can be used on histological, but also on cytological cell block, but also on smears specimen. On the first version of our panel, there were 27 genes known to be involved. And this panel is able to detect gene fusions, hotspot mutations, and gene expression levels. And why this is important to cover diverse areas of molecular alterations. I will come to it in a few minutes. So this panel can help to guide the diagnosis in uncertain cases and can detect also therapeutically relevant fusions. Here's an overview of what this panel can detect. We cannot go into each of these details, but if you are interested in, you can look it up in this paper. So I brought some cases to illustrate how the molecular sequencing can help. And this is the first case, number 1. And as you can see, this is the cell block specimen, where you can nicely see that there is an oncocytic neoplasm, almost no atypia. So this certainly could be an oncocytoma. However, this can be much more difficult than just an oncocytoma. So when looking into the whole case here, you can see that we detected here a CRTC3 MAML2 fusion when doing the molecular testing on this case. And this is a highly specific molecular alteration of mucoepidermoid carcinoma. We also did a FISH. You can see it here. This is the one allele shows fusion with a split signal here with a red and green signal divided. So this corroborates further this finding we had in the next generation sequencing. And the difficult thing here is that this is a purely oncocytic variant of an mucoepidermoid carcinoma, or so-called OMAC. And these tumors can be completely devoid of mucous cells, which can be very difficult to diagnose without additional molecular. And the second thing, which is quite difficult in these kind of cases, is if you look in the image E, you can see that there is a second population of cells which is positive for p63. And unfortunately, this is more or less the same picture you can see in oncocytoma, as oncocytomas are not monophasic but biphasic neoplasms, which always have a second population of p63 or p40 positive myoepithelial or basal cells. So even with this immunohistochemistry, you cannot reliably distinguish them. And so some of these oncocytic neoplasms can indeed be camouflaged mucoepidermoid carcinomas. So this fusion is the CRTC3. This is the rarer one, but most common you can find the CRTC1 MAML2 gene fusions. And in the literature, you find data approximately 60% of the cases harboring these kind of cases. But there are some authors, and this includes also my opinion, that maybe it's in up to 100%. So cases which do not harbor these fusions are really, you have to question if these are real mucoepidermoid carcinomas, because in my experience, really almost all of the cases do show one of these two fusions. So this is a very good and reliable tool to corroborate the diagnosis of mucoepidermoid carcinoma. So it's really a reliable diagnostic marker. Also in unusual variants, if you look in the literature, you will find lots of new variants being described, but almost all of them show the CRTC1 or 3 MAML2 fusion. So it's really helpful also in the unusual morphological variants. Okay, so this was one example from the oncocytic group. So I want to continue now with the monophasic neoplasms, which means that there's only one cell type. And here's one case from our routine from the parotid gland. And you can see here there are epithelial complexes, in particular with slightly atypical nuclei, and certainly lots of intracytoplasmic vacuoles. And also in the cell block specimen, which you can see here, you can appreciate that there's lots of cytoplasmic vacuolization, and maybe there's some hobnailing. So this is certainly some unusual morphology, which is not seen usually not seen in a conventional PA. So we did some additional immunos. Here's the S100, which was quite positive here. And also the mammaglobin was nicely positive in the cell block specimen, as you can see here. And here's the most important and diagnostic marker, the pan-Trk immunohistochemistry, which is nicely and strong positive in a nuclear manner. And this is important as the pan-Trk immunohistochemistry or n-Trk immunohistochemistry can often be positive also in other fusion-driven tumors. Also, if the tumors do not harbor an n-Trk fusion. However, then usually it's a membranous staining. So with membranous stainings, you always have to be very careful if this is really something which harbors an n-Trk fusion. And I would advise to corroborate these kind of findings always on a molecular level and do not rely on the membranous n-Trk staining. However, if you have a nuclear staining together with the S100 and mammaglobin positivity, it's almost 100% diagnostic for a secretory carcinoma. Here's the sequencing of this case, and we found the typical ETV6 n-Trk3 fusion, which can be found in approximately 95% of secretory carcinoma. So if there's a nuclear pan-Trk immunohistochemistry positivity, this is usually highly diagnostic of this kind of fusions in the salivary glands. So the final diagnosis here was secretory carcinoma. Here are two images of another entity which can mimic the secretory carcinomas. It's the so-called intraductal carcinoma. Unfortunately, the name is not optimal as we know, and there will probably some changes in the future. However, at the moment, it's still intraductal carcinoma. And the main differences are shown here. You can see the pan-Trk, nuclear pan-Trk immunohistochemistry positivity in the classical ETV6 n-Trk3 gene fusion positive secretory carcinoma. P40 is usually negative. And on the other hand, here in the intraductal carcinoma, you usually see a myoepithelial layer or basal cell layer, which is positive for P40, and the pan-Trk immunohistochemistry is usually completely negative. You have to be careful always when dealing with secretory carcinoma that there are approximately 5% of cases which do have non-canonical fusions. So there can be sometimes ETV6 ret or ETV6 met fusions or something. And these cases might be then or are then negative for the pan-Trk immunohistochemistry. So a negative pan-Trk immunohistochemistry does not rule out for sure a secretory carcinoma, as there are some variants with different fusions, but it's very rare. It's below 5%. Here's another monophasic neoplasm, and always there's often difficulties about the name. It's called polymorphous adenocarcinoma. And polymorphous means here that there's a polymorphous growth pattern, but the cell type, the cell type itself, this is monophasic. So this is a monophasic neoplasm. They're usually positive for S100, and they often show reactivity, heterogeneous reactivity for P63 and negativity for P40. However, this does not work at any time because you have to be aware that there are some clones of the antibody clones where it's not working. However, in general, this is the immunophenotype you would expect. And there are two variants, the conventional subtype, as you can see here, with this target to it perineural invasion. And you can find the Grippiform subtype, or also found as Grippiform adenocarcinoma in the literature, which show papillary growth like this, or glomerulate growth like this. They often show a more aggressive behavior, so they have an increased level of lymph node metastasis. However, they usually have anyways a good prognosis. The good thing about these entities is that they have very specific and very common or frequent molecular alterations. So the conventional subtypes, in most of the cases, we do find a E710D mutation in the PRKD1 gene. And in the Grippiform subtype, most of these cases do show gene fusions of the PRKD1, 2, or 3 gene. So covering these kind of genes can help to corroborate the diagnosis of these entities. Most often, it's like the conventional subtypes show the mutation, the point mutation, and the Grippiform subtypes show gene fusion. However, there are some exceptions to this rule, but very, very rare. And as written here, there's a higher likelihood of lymph node metastases depending on the pattern and also depending if there's a gene fusion or not. Okay, let's move on to another case. Of this case, you can see already here very lymphoid background, and here these epithelial complexes, and also in the cell block specimen, which is shown here, you already are able maybe to appreciate some cyanogen granules here. And if you have suspect of an actinic cell carcinoma, there's a very good and reliable immunohistochemistry, is the so-called NF4A3 immunohistochemistry. Here's it, and it's positive in the epithelial cells, in the tumor cells here, and negative in the lymphoid cells, and also in normal actinic cells. It should not be expressed, so it's a very sensitive and specific marker for actinic cell carcinoma. So this is the diagnosis of an actinic cell carcinoma. Often it can be easy also in the cytology as a specimen, but sometimes it can be difficult if it's only sparse material, sparse tumor cells, or if there's a high-grade transformation. So what about this gene? It's the NF4A3 gene, and it's upregulated in actinic cell carcinoma. Usually you can see here the nice nuclear immunohistochemical positivity for the NF4A3 protein, which is then produced due to the upregulation. And it's, as I said, very sensitive and specific for actinic cell carcinoma. And it should be negative here in the control group here on the right side. This was a secretory carcinoma, which can morphologically mimic actinic cell carcinoma, but are usually then, as I said, pan-track nuclear immunohistochemically positive and negative for NF4A3. And also in our panel, as I said, we use mRNA expression levels, and you can see it here. And all of our actinic cell carcinoma in the validation study showed high expression values of the NF4A3 mRNA compared to control cases, which almost showed no NF4A3 expression. It can then be used for normal variants on histology. Here's an example on the left side. But also here on the right side, you can see this is an actinic cell carcinoma with high-grade transformation, which is indeed rare, but can sometimes occur. And then it gets more and more difficult to make an entity diagnosis due to the loss of cyanogen granules. However, in our experience, also there, the NF4A3 immunohistochemistry works well to corroborate the diagnosis if you're suspect of a unusual actinic cell carcinoma. So why can't we just detect the NF4A3 fusion? And this is a very interesting thing I want to go a bit deeper into. So here you can see the NF4A3 gene. And here this is the FISH probe, the usual NF4A3 FISH probe covering the area around the NF4A3 gene. And what happens, and it has been described by Florian Haller and colleagues in 2019, is that so-called super enhancers do rearrange upstream of the NF4A3 gene. And this is important as this is in the intronic region here, so we cannot detect these kind of alterations or fusions with an mRNA based test, because we only can cover the NF4A3 gene itself, but not this enhancer region. And when these enhancers translocate upstream of the NF4A3 gene, then it leads to a strong upregulation of the NF4A3 mRNA and also of the protein. And here you could see, for example, a positive FISH. If the breakpoint would be here, then you would probably have a dislocation of both probes. But if it would be here, for example, you would not even see a positive FISH. So the FISH would be negative. The NGS would also show no translocation. But what can we detect? We can detect the high level of NF4A3 expression on mRNA and also on protein level with the easiest way using the immunohistochemistry. Okay, so let's move on to the biphasic neoplasms. So for the biphasic neoplasms, for the benign ones, or the most common benign ones, we have the pleomorphic adenoma. However, pleomorphic adenoma is most often not biphasic alone. They often have a mixture of biphasic areas, which are structured epithelial and myoepithelial differentiation, and they have areas with only myoepithelial differentiation or only epithelial differentiation. So usually it's a mixture. That's also why it's called pleomorphic. It has pleomorphic differentiation, and most of these cases show a PLAG1 or HMG gene fusion. So if we can detect one of these, we have a strong argument to call something from the spectrum of pleomorphic adenoma. Then the basal cell adenoma, also this name is a bit misleading. However, this is a purely biphasic neoplasm consisting of epithelial and myoepithelial cells throughout the whole lesion. And these lesions show you can see in the literature, there's a broad range between 37 and 80%, and there are new papers now coming showing also alternative point mutations in other genes, which seem to cover the other spectrum, which are CTNNB1 negative. However, approximately up to 80% harbor these CTNNB1 gene mutations. And there's cyst adenoma, which is quite rare, and there's no known alterations yet. Okay, now we move on to the malignant biphasic neoplasms, and one of the most important ones certainly is the adenoid cystic carcinoma, which is very important to correctly diagnose, in particular on fine needle aspiration. And here we have good tools such as the MIP and MIPL1 gene fusion, which together have approximately 60 to up to 80% of the neoplasms. So if there's suspect of an adenoid cystic carcinoma, many or most of the cases can finally be diagnosed in difficult cases using additional molecular testing for MIP and MIPL1. Then there's certainly the epithelial myoepithelial carcinoma, which has a high level of HRAS gene mutations, sometimes combined with PIK3CA or ACT mutations. But the most important one is the HRAS mutation, which is certainly not specific, but if we have a biphasic neoplasm and we do find activating HRAS mutation, then there's a very high chance that this is an epithelial myoepithelial carcinoma. Then there's basal cell adenocarcinoma, much rarer and also not very well characterized on molecular level. We know that there are these CYLD gene mutations, approximately 30%, so rather low, and very rarely CTNNB1 gene mutations. So it seems that basal cell adenoma and basal cell adenocarcinoma are two really distinct entities, and that there's usually not a usual conventional sequence that you first have a basal cell adenoma, which then develops a basal cell adenocarcinoma. There might be very rare cases where this is the case, but in general, these are really two distinct entities with different molecular profiles. And as I said, the intraductal carcinoma, biphasic, and approximately half of them harbors RET gene fusions, NCOA4 or TRIM27, TRIM33 RET fusions. And there are other point mutations, very rare BRAF mutations, or more common HRAS and PIK3CA gene mutation. So here's another example case of a parotid gland FNA, and here you can see some epithelial areas here with these duct formation, and certainly around these ducts you can see another population which looks like myoepithelial cells. So in this, at least in this specimen, it looks like a biphasic neoplasm. We don't see any obvious stroma or something, so difficult to characterize. And here we did the sequencing, and we did find a classical CTNNB1 PLAG1 fusion, which is very typical of a pleomorphic adenoma. And here's the resection specimen. And here you can see another area where you have the conventional chondromyxoid stroma. However, if you look at these areas here, they can look really very, very similar to epithelial myoepithelial carcinoma. And there, the molecular testing can really help if you have an HRAS mutation, which strongly points to an epithelial myoepithelial carcinoma. And if you have a PLAG1 or HMG fusion, this strongly points to a pleomorphic adenoma, to a cellular PA. Here on the left side, you can also see well circumscribed, encapsulated neoplasms. So this is a cellular PA or pleomorphic adenoma here. Here's another case with only very scarce material. But again, you can see here some epithelial formations, here some duct formation, and around probably the myoepithelial cells. And in the molecular sequencing here, there we did find a very classical Q61R HRAS mutation, which then strongly points to a epithelial myoepithelial carcinoma here. So epithelial myoepithelial carcinoma, so here on the left side, you can see a normal histological morphology of these tumors. They often have cytoplasmic clearing of the outer myoepithelial layer and more eosinophilic morphology of the inner epithelial ducts. And it's always biphasic throughout the whole lesion. Sometimes you will find EMCs with myoepithelial overgrowth, and then it's getting even more difficult to distinguish them from PAs, in particular on small biopsies or on FNA. Here's the typical pattern of morphology of the RAS Q61R antibody. This is a mutation-specific antibody. However, it's not HRAS specific. It also can detect NRAS because the sequence in this area is the same. So if this antibody is positive, this points to a RAS Q61R mutation, and this could be either HRAS or NRAS. So you cannot predict per se which RAS is altered here. But together with the biphasic morphology and the spared, usually the spared inner epithelial ductal layer, this is very characteristic of epithelial myoepithelial carcinoma. Here's another case of an epithelial myoepithelial carcinoma. And here on the right side, you can see also how immunohistochemistry can help to corroborate the biphasic differentiation. So you can see here the inner epithelial or ductal layer, and you can see outside here the myoepithelial cells, which are usually then positive for P63 and or P40. So this can help to show or to visualize that this is a biphasic neoplasm. So in particular, in unusual variants, it can be very difficult. So for example, this case also showing an HRAS Q61R mutation. And on the right side, you can see it's more basaloid morphology. And sometimes EMCs can show very weird variants, which can be very difficult to diagnose. So there can the HRAS detection of an HRAS mutation can really help to corroborate the diagnosis. Here's another case, also the cell block specimen. Here it's very difficult, almost impossible to really see that this is a biphasic neoplasm. Here's a little bit of duct formation. So that's always what I do when I look at the salivary gland neoplasms. The first thing to look if I can find some ductal formation. Here's some, and here you can see the P40 immunohistochemistry. And this is very nice to see that we have a biphasic, a very organoid biphasic differentiation here throughout the whole lesion, or at least throughout the whole specimen we have here. And this case was also sequenced and showed a quite a typical CTNMB1 mutation. So here the final diagnosis is a basal cell adenoma. We have to always be a bit careful if we have only the molecular, if we have the molecular findings, or if we have only the immunohistochemical findings. So here is a resection specimen, and here you can see a very well circumscribed, encapsulated neoplasm, basaloid, also here the ductal formation, and here you can see the typical beta-catenin positivity, nuclear positivity in some of the myoepithelial cells. And this is very important to appreciate this kind of pattern, because this is something which is in my consultation practice, which is often mistaken for a negative result. So this is a very typical result that you only see the beta-catenin nuclear reactivity in single myoepithelial cells within a basal cell adenoma. So be careful to really look exactly on the slide of the beta-catenin, because this is, as I said, a typical positivity for beta-catenin. And the thing is that the beta-catenin reaction, the nuclear reaction, is non-specific for a CTNMB1 mutation. Certainly, if you have a CTNMB1 mutation, it usually leads to nuclear translocation of beta-catenin. However, in this pathway, there might be other mutations in other genes which can also lead to beta-catenin nuclear reactivity. So if you only have the immunohistochemistry, then this points to a basal cell adenoma by chance. However, there are sometimes also basal cell adenocarcinomas which can show beta-catenin nuclear reactivity, but usually they are negative on the molecular sequencing. So depending on this, it's depending also on the clinical aspect, it's sometimes better to just call it that it's a lesion from the spectrum of basal cell neoplasm, and the final diagnosis, if there's invasion or not, has to be made on the resection specimen. And also another very important differential diagnosis here. Probably you already saw what we are dealing with, this grippiform growth with the with also this spherical extracellular material. Here in the sequencing, we did find a classical MIP-NFIP fusion, which is diagnostic of an adenoid cystic carcinoma. And even in unusual variants, if you find in a salivary gland neoplasms this fusion, this is really highly specific for an adenoid cystic carcinoma. And here's the resection specimen already showing here the perineural invasion. So MIP-NFIP or MIP-L1-NFIP fusions are highly specific for adenoid cystic carcinoma, but certainly you always have to correlate these molecular findings with morphology and the immunohistochemical profile. So approximately 60 to 80% show a MIP-NFIP or MIP-L1-NFIP gene fusion. So what about the other 20%? Actually, we don't know, but probably there are also cases which do show enhancer hijacking, as I showed for the actinic site carcinomas. So some authors also recommend, for example, RNA in situ hybridization for MIP mRNA, for example, which is stabilized and which is overexpressed also in cases where you do not find a gene fusion. So this could also help to corroborate fusion negative adenoid cystic carcinoma. And there's also an important subset with so-called Notch1 alteration, and these are approximately 50% of cases. It's enriched in the solid growth pattern, and they usually show a very aggressive biological behavior. So these cases are often already metastasized when diagnosed, or they have metastases within 1 year after diagnosis, often to liver, bone, and they are really distinct from conventional adenoid cystic carcinoma. So this is really a distinct subtype, and they are usually also negative for P63 and P40. Interestingly, almost all of the cases, and this is also our experience when sequencing these kind of cases, show the mutation in the so-called PST domain. As you can see here, these are frameshift or terminating mutations most often. So the PST domain is a negative regulatory domain, which is disabled due to the mutations and then leads to an enhanced Notch1 signaling. But in this context, it's also quite typical if you have a basaloid neoplasm with expression of SOX10 and CD117 and a PST domain mutation. This is very, very typical for a solid variant of an adenoid cystic carcinoma, even if you do not detect a MIP alteration. Okay, so these were some cases, some illustrative cases I wanted to show you, and in the last minutes, I want to show you also a multi-center study we performed because we wanted to try to objectify the findings with single cases we had, how molecular testing can help when dealing with difficult neoplasms of the salivary gland. And we did a multi-center study together with the University of Leiden and University of Leuven in Belgium. And we had a total number of 63 cases. They were from Milan categories 4B and 5. And we did the self-gland DX panel on these cases. And almost 76% of the cases showed an alteration. So there was a high yield of alteration detection in these cases. So we had 24% where we did not detect anything, but most of the cases harbored a gene fusion, and a significant proportion also a gene mutation. So what we then did, we calculated the risk of malignancy according to the dignity of the resection specimen. So we had the resection specimen of these cases. And here below, you can see what kind of alterations we detected in our study cohort. And as you can see, there was a high number of PLAG1 fusions, 2022 cases, which reflects that pleomorphic adenomas are very common in our daily routine. And we had a risk of malignancy when detecting this fusion of 0%. Certainly, we have to be very careful about this because this is not a very large study, and probably the risk of malignancy will increase with increasing the study size. However, together with the HMGA2 fusion, which also reflects a very characteristic alteration in pleomorphic adenoma, together we had a risk of malignancy of 3.4%, which approximately reflects the risk of malignancy when using the Milan category 4A. So there's also always a small risk that there might be an undersampled or non-sampled, for example, carcinoma XPA, even if there is classical chondromyxoid matrix. When there was no alteration, we had a risk of malignancy of 27%, which still reflects the risk of malignancy range in Milan 4B categories. But as you see here, also again, MAML2 fusion were always malignant, mucoepidermal carcinoma, HRAS were always malignant with different kind of carcinomas. However, there are very rare benign tumors in the salivary gland, which might show HRAS mutations. So if you have a HRAS mutation, it's certainly not specific for malignancy, but it's really strongly pointing to a malignant neoplasm within the spectrum of salivary gland neoplasms. And MIP and ETV6 fusion were rare, but also specific for a malignant tumor. So then we looked, how can we redefine and how can we use the molecular findings to change the category to a more certain category, such as 4A or 6. And in 71% of all cases, the category was differing afterwards, after including the molecular data. And as you can see, in 94% of the cases with a molecular alteration, we were able to change to a different category. Then here you can see in particular the difficult category 4B. This is what we found in this group. In 76% of the cases, we found an alteration. And in almost all alteration positive cases, we were able to redefine it to either 4A, benign, or to 6, malignant. There was only one case here with a very specific and unusual fusion, which we did not redefine due to this specific fusion. So to sum up our study, we could show that it's feasible to do on cytology. We can either do it on cytology on cell blocks, but we can also do it on smears. And from our experience, it's much better to do it on smears, which are not formalin fixed, paraffin embedded. So the best way is to use one smear for the molecular testing. We have a high alteration rate. So among the valid cases, 76% harbored a molecular alteration. And we were able to refine the classification when including the molecular findings to a more definitive Milan category, either benign or certainly malignant. For example, if you do find a MIP-NFIP fusion in a case where we're not sure if this is a cellular PA or an adenoid cystic carcinoma, and you find a MIP-NFIP fusion, there's certainly a very, very high probability that this is an adenoid cystic carcinoma, almost 100% if everything worked well. And some alterations had strong predictive value. For example, as I said, HRAS mutations correlated with 100% malignancy. However, we have to be aware, and I have to emphasize this, it's certainly not 100% in a larger cohort, but it's strongly pointing to a malignant neoplasms. And PLAG1 and HMGA2 fusions were largely associated with benign lesions. So if you're unsure if this is a cellular PA or maybe something, or an adenoid cystic, and you do find a PLAG1 fusion, then there's a very high chance that this is a pleomorphic adenoma, a cellular pleomorphic adenoma. And then there's probably still a risk of malignancy of maybe up to 5% or something, that there might be some carcinoma XPA or something hidden in the specimen, which we are not able to detect by morphology or by molecular investigation. Here's another bonus case I wanted to show you to sum this up. So this was quite a recent case with this highly atypical neoplasm in the parotid gland, and we did some additional investigations. And for example, the pancytokeratin was negative at the beginning, so we did not find any reactivity. However, the specimen was limited. Here's the S100 immunohistochemistry. There were some very faint nuclei, so we weren't sure maybe this is true or not. Probably this is something really poorly differentiated here. And then we did sequencing on this case and found a BRAF mutation, a classical V600E mutation. And so we're discussing if this is a salivary gland neoplasm at all, because as I said before, BRAF mutations are very rare in the salivary gland. So if you do not have the conventional morphology of a epithelial, a neoplasm, or the typical immunohistochemical profile you would expect, then in particular, together with a BRAF mutation, you have to be very careful. Here's another immunohistochemistry we stained under the knowledge that this lesion has a V600E BRAF mutation, because we're thinking, okay, there seems to be a bit of S100 reactivity. We stained for Langerhans because we know that Langerhans cell histiocytosis recurrently show BRAF V600E mutations. And there was indeed several cells positive. So at the end, we weren't able to certainly tell what this is. And after this, they did the resection. And as you can see here, this is the parotid gland resection with a certainly positive lymph node here. And this was the lesion. And when magnifying this, you can see this is these highly atypical cells, even with rhabdoid features. And on histology, it was easy because all of the typical melanocytic markers were expressed. So this was a metastatic melanoma, indeed, mimicking and camouflaging here with a very, difficult to type, even with molecular testing, difficult to type lesion. So at the end, the learning from this case was that with the BRAF mutation in a salivary gland specimen, you have to be very careful because in a primary salivary gland neoplasm, it is very rare. So the take-home messages are comprehensive molecular testing on FNA material is feasible and can help to corroborate the diagnosis and also the dignity the correlation with morphology and the IHC profile is mandatory. So this is really important. As I showed, there's just a BRAF mutation. There's a large spectrum of potential entities which can be behind this mutation, and you cannot rely just on one molecular alteration without considering all the other groups of morphology and immunohistochemistry. The NF4A3 and the PanTrack immunohistochemistry are highly sensitive and specific in the context, in the correct context. SOX10, P63, and P40 can be helpful for further characterization, in particular regarding cellular PAs, for example. However, in many of these neoplasms, they are quite similar. So without additional testing, it can be sometimes impossible to really distinguish between different kind of entities and also dignities. Here I also sent 2 red flags. So BRAF mutations are rare in salivary gland neoplasms. So consider melanoma or other entities, metastases, whatever, but consider anything else than SGN in addition. And also the red flag is if you're considering an oncocytoma and P63 and P40 are negative, be very careful, because then there could be also other entities behind where can camouflage as oncocytoma or oncocytic lesion. So with that, I want to thank you very much for your attention from all over the world, and I'm happy to take questions.